Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Importance of Stringent Complete Response Following Autologous Stem Cell Transplantation in Multiple Myeloma by Prashant Kapoor et al. My name is Ken Anderson, and I am Director of the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, Mass. My specialty is hematology oncology, focusing on multiple myeloma. There has been remarkable improvement in patient outcome in multiple myeloma due to the development of high-dose therapy and autologous stem cell transplantation, coupled more recently with the use of novel therapies, primarily the immunomodulatory drugs and proteasome inhibitors. Prior to the advent of novel therapies, high-dose therapy and autologous transplant was the only modality which achieved complete response, which in turn correlated with prolonged progression-free and overall survival in some studies. Remarkably, the use of novel therapies in combination can now achieve increased extent and frequency of response associated with improved outcome even in non-transplant eligible patients. Most importantly, integration of novel therapies into the transplant paradigm as induction, consolidation, and maintenance therapy has prolonged median survival at least 2 to 3-fold. Indeed, due to this high frequency and extent of response to combination novel therapies, randomized clinical trials are now evaluating the outcomes of combination novel therapies with or without autologous transplant. With this remarkable progress in multiple myeloma has been the parallel development and refinement of uniform and more stringent response criterion by the International Myeloma Working Group. This criteria defined very good partial response as 90% or greater reduction in serum M protein with 24-hour urine M protein less than 100 milligrams. Patients with less than 5% bone marrow plasma cells and M protein detectable only by immunofixation but not by electrophoresis are considered near complete response. Complete response is the absence of soft tissue plasmacytomas, less than 5% bone marrow plasma cells with no M protein on immunofixation. And stringent complete response requires the absence of monoclonal bone marrow plasma cells and a normal kappa lambda free light chain ratio. Although not yet incorporated into standardized International Myeloma Working Group response criteria, more stringent molecular complete response is defined as the absence of residual bone marrow myeloma cells as measured by allele-specific polymerase chain reaction or by multicolor immunofluorescence, referred to as immunophenotypic complete response. Finally, recent studies are assessing the utility of PET-CT scanning not only for its diagnostic and prognostic utility, but also for its ability to detect minimal residual disease in the bone marrow, as well as at extramedullary sites. In the article that accompanies this podcast, Kapoor and colleagues report on 445 patients with multiple myeloma who underwent autologous transplant within 12 months of diagnosis. Attaining stringent complete response post-autologous transplant portended longer overall survival, median not reached, compared to either conventional CR with a median of 81 months or near CR with a median of 60 months. The 5-year survival rates were 80%, 53%, and 47% respectively for these 3 complete response categories. Median time to progression for patients attaining stringent complete response was 50 months, which was significantly longer compared to that of patients achieving conventional complete response or near complete response, whose median time to progression was 20 and 19 months respectively. Importantly, multivariate analysis identified stringent complete response achieved post-autologous transplant to be an independent prognostic factor for survival. The major important implication of this study is that patients achieving stringent complete response and conventional complete response should be reported separately in clinical studies due to their distinct outcome. Although this study strongly indicates that more stringent complete response portends improved outcome, there are several potential limitations. There is heterogeneity of treatment in patients included in this retrospective study, which spanned from 2002 to 2008, when treatment strategy with novel therapies was evolving and both induction and salvage therapies improved. Moreover, some patients received tandem transplants, some received maintenance therapy, and salvage therapies were not uniform. Importantly, bone marrow biopsies to assess for complete response were not uniformly performed in a pre-planned fashion. The implications for this study for current-day practice are unclear, since recent studies have demonstrated the benefit of incorporating novel therapies such as bortezomib into induction therapy, the utility of consolidation therapy with novel therapies, bortezomib, thalidomide, and dexamethasone, to increase the extent and durability of response, and the ability of maintenance treatment with agents such as lenalidomide to increase progression-free and overall survival. In addition, conclusions regarding overall survival are also confounded since salvage therapy was not uniform and effective salvage therapies varied. For instance, lenalidomide and dexamethasone was available in the earlier years of this study, and more effective recent salvage therapies now include carfilzomib and pomalidomide with low-dose dexamethasone. In spite of these limitations, this study does support reporting outcome of clinical trials using more stringent uniform response criteria. Historically, high-dose therapy in autologous transplant was the first modality to achieve frequent complete response, which correlated with prolonged, progression-free, and overall survival. Multiple studies have more recently shown that novel therapies, even without autologous transplant, can achieve complete response, which again correlates with outcome. Specifically, high-dose melphalan can increase the extent of response achieved during induction therapy. Consolidation therapy post-autologous transplant can significantly increase the rate of molecular complete response, and maintenance therapy with novel treatments can further improve extent of response as well as prolong both progression-free and overall survival in some studies. In the past, molecular complete response was achievable and had prognostic value only in the setting of allogeneic transplantation, but integration of novel therapies into the autologous transplant paradigm can now result in frequent molecular complete response, which in early studies also has prognostic value. Finally, the MRC9 trial recently showed that immunophenotypic complete response, defined by the absence of minimal residual disease as assessed by multicolor immunofluorescence at day 100 post-autologous transplant, predicted for favorable outcome. This study also demonstrated that maintenance thalidomide therapy further increased the likelihood of achieving immunophenotypic complete response and improved outcome. Ongoing studies are now evaluating techniques for detection of minimal residual disease in myeloma, including polymerase chain reaction, multicolor immunofluorescence, and sequencing-based methods. Importantly, achieving complete response can now be a reasonable goal in the majority of patients with newly diagnosed disease. However, only when a standardized methodology is available, which can be broadly applied and quality controlled, can the clinical significance of absence versus presence of minimal residual disease in myeloma be prospectively determined. This need for uniformity of complete response definitions is highlighted by a Spanish trial of 102 patients with myeloma treated with novel therapies in which the outcome was equivalent in patients with conventional complete response and stringent complete response, which therefore appears discordant with the current study. However, Definitions in these two studies were different, since stringent complete response in the Spanish trial did not require the absence of monoclonal plasma cells as in the current study. Indeed, in both studies, immunophenotypic complete response conferred benefit. In conclusion, achieving complete response is now a reasonable goal for an increasing number of patients with myeloma, and future clinical trials must therefore incorporate uniform and stringent complete response definitions to both assess the relative effectiveness of novel therapies and inform optimal treatment duration. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.